Morning, everyone, and welcome to May 9th Cardiac Science Grand Rounds. Today it is my great honor to introduce Dr. Alonso-Gonzalez. Dr. Gonzalez is originally from Spain, where he did most of his cardiology training. He then moved to London, where he worked at the Royal Brompton for about a decade as an adult congenital doctor. And then more recently, he had moved to Toronto to take over, well, initially to be a doctor, a congenital doctor in Toronto, but later to become the director of the Toronto Adult Congenital Disease Program. So he visits us today, very familiar with a large number of our trainees, it turns out. He trained some of them in London, he trained some of them in Toronto, but in many ways, he's one of the fathers of Calgary's Adult Congenital Heart Disease Program. That's not true, right? Yeah. He's today going to give us a talk on heart failure and adult congenital heart disease, what makes it different. So,
thank you for the kind introduction, and thank you for inviting me here. Thank you for the congenital program to have me here today. So we're going to talk, or I'm going to try to talk today about, in the next 45 minutes, about heart failure and congenital heart disease, which is one of the biggest problems we have, but mainly to try to make a comparison with what is the heart failure in non-congenital patients and why the congenital heart disease heart failure is different and probably needs a different management. If this works, yes. So if we have done very well in the congenital heart disease world is just in the last 50 years, we reduced significantly the mortality of children that are born with congenital heart disease. And if you look at the numbers, although these are data from Quebec, which are old, but these are unreproducible today, of number of adult patients with congenital heart disease, in every single unit is double than the number of pediatric patients with congenital heart disease. So we shift the mortality from the early days to patients that we have now in the geriatric age, and we all of us who have in the unit patients with 70 or 60 or 70 years old. Of course, this is what I call the price of your own success. This comes with a toll to pay, and many of our patients going to develop heart failure. This one very interesting study done in Sweden, where they look at 22,000 patients with congenital heart disease born between those years, and they follow them for 40 years. So in black, you see the normal population, and in red are the congenital patients, and they look at who going to develop heart failure during follow-up in the next 40 years if you are born with congenital heart disease. And they saw that the chances of developing heart failure you have congenital heart disease is 300% more than a non-congenital heart disease patient. But more interesting is, like, even if you have a simple congenital heart disease, you have almost 7% more chances of developing heart failure. But if you are born with a complex congenital heart disease, that goes to 15%. And if you develop heart failure, your risk of death is around 63%. In the congenital population. And we are talking about patients with 40 years old. So we have been very successful, but we are paying a price with this population. When I was at the Brompton, we did an exercise looking at our heart failure admissions for the previous 2 years. And on the left, you see the number of patients admitted more than twice for heart failure. On the right, you can see the number of patients admitted for more than 4 times within a 2 years period for heart failure. And you can see how the number of patients increase exponentially. And the older the patients are, the higher is going to be the risk of admission for heart failure or the risk of developing heart failure. A group from Quebec did a couple of years ago, they looked at the predictors of admission for heart failure. So what makes you to be at risk of being admitted for heart failure if you have congenital heart disease? And you can see that if just the highest risk of predictor risk is if you develop heart failure, your risk of being admitted again for heart failure is 5-fold. And along with other risk factors, they came up with this risk score, which I'm not going to go into detail in the risk score, but which the risk score says that it's cumulative. And if you reach up to 8 points in this risk score, which include, as you see, things like previous admission for heart failure, or having pulmonary hypertension, or having chronic kidney disease, or coronary artery disease, things that are very common to general cardiology. as soon as you reach 8, the risk of having an admission for heart failure increases exponentially in patients with congenital heart disease. So as this population gets older, they're going to have more and more of these comorbidities, and the risk of heart failure is significantly higher than the acquired heart disease population. But also our patients are in disadvantage if they get admitted for heart failure. This is a study done in the US, published almost 2 years ago right now. And they look at the administrative database in the US for patients admitted for heart failure. So they look at all patients admitted for heart failure in the emergency department. So if you have a congenital heart disease and you get to the emergency department for heart failure, if you compare to the patients with non-congenital heart disease, you are more likely to be admitted, which makes sense. Doesn't matter whether you have a single ventricle or 2 ventricles. But more interestingly, if you are admitted for heart failure, you are more likely to die during that admission if you have congenital heart disease. And that's not a surprise, because already in 2015, that the Gerhard Diller published this paper where they showed that actually, whereas at the beginning of the congenital heart disease period of your life, your higher risk factor for death is sudden cardiac death. So majority of our young patients die for sudden cardiac death. Until they turn 40, actually, the most common mode of death is heart failure. And the increase in the heart failure prevalence is exponentially from the 40 years old. So I think that, what we have is a big problem. I think we have a population that is growing older, has a higher risk of developing heart failure. And heart failure and congenital heart disease has a lot of challenges, which is what I'm going to try to explain why this is different. So the first challenge is obvious. So we don't deal with 2 ventricles, and the left ventricle is always the left ventricle, and the right ventricle, well, is always in the subpulmonary position. We have a massive heterogeneity population. So we have many patients that have a systemic left ventricle, but we have many patients with systemic right ventricle. We have a lot of univentricular hearts, but we also have a higher prevalence of right ventricular failure, which is something that in acquired heart disease normally comes after you develop left heart failure, but it's very unusual to have isolated right ventricular failure in acquired heart disease. But something that sometimes people don't realize, physiologically, our patients work differently. So we have patients with preload-dependent circulation, a concept that doesn't exist in acquired heart disease and very common in congenital heart disease. They have other problems that is gonna have a significant impact in their heart failure, which is like cyanosis or PLE, or they have a higher risk or higher prevalence of secondary hyperaldosteronism, which is gonna have a significant impact in how you manage these patients. What is the harder part of doing heart failure in congenital heart disease is to define heart failure in congenital heart disease. So if you are, if you use to or treat acquired heart disease patients, all of us know what is a left-sided heart failure, what is a right-sided heart failure. But very often our patients present to clinic and they're okay, and they feel okay, and they get used to be limited, and they don't develop the typical peripheral edema or shortness of breath. They come and tell you, well, I'm fatigued, or, takes longer to recover after I do a night shift. So the last Fontan patients I transplanted, the red flag was he stopped being able to do night shifts. He was a nurse. So these signs that if you are not trained to treat patients with heart failure, you actually can overlook and think that the patient is doing very well. So we don't have a clear definition of heart failure and congenital heart disease, and that is a problem. And you need to be aware that they can present of million different ways, and be alert that you don't miss a heart failure diagnosis. I find very useful to use CPET to monitor patients with congenital heart disease, not as much of an isolated number, but a follow-up number in a given patient to compare with itself. But when you do CPET in congenital heart disease, you have to adjust your interpretation of the report according with the anatomy of the patient. It's not the same to have an arterial switch, which is a patient with a biventricular heart and basically like a normal patient, or a normal acquired patient, that having a patient with a Fontan, which you do, the expectation is going to do less. And some of the Fontan patients might get to the area where you would even consider transplanting them because of CPET numbers, but actually maybe they're normal. So you have to be aware that the different anatomies have different PVO2s, and you have to adjust accordingly. But also you have to be aware that they present in different ways. And always when I talk about heart failure, I bring this case, which now might not play, but I'm sorry, it was playing before. But yeah, so this is a patient that when I was at the Brompton, I was on call, and this patient got to the local hospital for, he has shortness of breath for, I think that was a week, and a little bit of edema in the last 2 days. And he came, we gave some diuretics, we did MRI, and for those that are not familiar, so this is a single ventricle, so this is a tricuspid atresia, this is a left ventricle, this is mitral valve that is moving now, this is the left atrium, and all of these huge things here is a RA2PA Fontan with this monster in the middle, which is a clot. So that is how he presented with heart failure, and this is not, you cannot give this patient just only diuretics and inhibitors and it's going to be okay. Patient had to do, we had to do an emergency operation, remove the clot, and convert him to a TCTC. Which leads us to the next point, is what do you do first when you have a congenital heart disease patient with heart failure? So this is a good paper that compare what is the main difference between acquired heart disease heart failure and congenital heart disease heart failure. So if you do heart failure and acquired heart disease, and my background, I'm a cardiologist, I train in heart failure before training in congenital heart disease. And you have somebody with LV dysfunction, you just give ACE inhibitors. Neurohormonal modulation has shown to improve survival in patients with acquired heart disease. That's the first thing you do before even thinking about anything. After you say, well, I might need a CRT, might need an ablation. We'll see what happens. Might need an ICD, and if it doesn't work, well, you might decide to do a cath to see because things are not going well. And the last thing you're going to do is any kind of intervention that is surgical or structural intervention in a patient with heart failure. Now you can do a mitral clip or a atrial clip, but it's not, you don't want to start doing a mitral clip in somebody with heart failure as a first stage. Whereas if you have a congenital heart disease, the first thing we're going to do is to do a cath invasive and see what is wrong with this patient, what we can fix, because the most likelihood is that this patient is in heart failure for something that actually is a residual lesion of what they had before, and we might be able to fix it, and we will resolve the heart failure. So the first thing we're going to do is to do an invasive assessment of the patient, look at the structural intervention we can do to fix that patient. We're probably going to do a device or any kind of other intervention before even we consider to give them medical therapy. And that is because we will see later on, we don't have much evidence of medical therapy in congenital heart disease. If you just want to have an algorithm, there are a million algorithms of how to try heart failure, treat heart failure and congenital heart disease. I don't bring this algorithm here to go through how to treat it, but I find interested in this algorithm that medical therapy is here, down here. Before, there are a million things that you have to do. That's the patient has arrhythmias, has another comorbidities that actually I need to treat for the heart failure before even giving medication. So I have to do an invasive assessment. It's anything, any intervention, surgical or percutaneous that I have to do. And it's only after I rule out all of this when I consider to treat the patient with medical therapy. Why this is the case? Because, I miss my days when I did heart failure in acquired heart disease, because, it's lovely to have guidelines like this. They just tell you, you have million medications, they improve survival. You can give everything to them now. And you know that you are doing something good for the patient, because it's actually all of them now increase survival. And in the last years, we had 2 more added to the group of medications that we use in heart failure. And it's great to have this. But the problem with heart disease, of course, because we don't have much, we try to copy what works for acquired heart disease. But the first thing that I think you have to be absolutely aware when you treat heart failure and congenital heart disease is we don't treat the same patient, because every patient has a different physiology. So the physiology of your patient is key when you decide what medication you give to them. And one of the if not my favorite, if I was about to say one of the most of my favorite papers, but probably this is my favorite paper in congenital heart disease that shows extremely well how patients that seems to be equal or similar have a different physiology. So though these are this group that got patients with systemic RV, so patients where the right ventricle is the one that's pumping to the circulation. And we have two models, which is the ccTGA, which is the congenitally corrected transposition, the ones that are born like that. We haven't done anything to them. They are born like this, and the systemic RV is in that position from birth, just correct, just without any operation, many of them. And then you have the TGAs, which we made them to have a systemic RV with a master of ascending. And they look at, they gave them dobutamine, and they look at the response to dobutamine of these patients. So they saw that both of them, both groups, both the ccTGA and the atrial switch were able to increase the cardiac output, or the cardiac index, sorry. But when they look at how they increase the cardiac index, although both of them were able to get tachycardia, only patients with ccTGA were able to increase the stroke volume. So why this is important, imagine that you have a population, a patient that doesn't able to increase the stroke volume, and we will see that a little bit later. You give a vasodilator, and if you don't increase the stroke volume, actually you might reduce cardiac output. So physiology is important when you just consider what medication you're gonna give to your patients. The good thing and the good news is that majority of our patients have a systemic left ventricle and have a biventricular heart, two ventricles, two atriums. And this is a study recently published from the Mayo Clinic that they look at 4,000 patients with congenital heart disease, and in 554, so 12% of them have a left-sided, so a left ventricular systolic dysfunction. And they look at what guideline medical therapy or CRT does to these patients, and they saw that actually the ejection fraction increases if you just use the standard therapy. And when they look at those that had isolated a primary right problem, so let's say a fallow with an associated left heart disease, actually guideline medical therapy was much better than doing an operation on the pulmonary valve or any action on the right side. So a good, just for those that don't do congenital heart disease, this belief that if you have a fallow, 30% of patients with fallow have LV dysfunction. And this is believed that if you have a fallow with severe PR and LV dysfunction, if you change the pulmonary valve, the LV function improves, which is true as to a certain point. But they prove that if you have a significant LV dysfunction, changing the valve is not as good as giving them guideline medical therapy. So if you don't do congenital heart disease, but you can come across a patient that has 4 chambers and all of them connect normally, and they have LV dysfunction, just forget about the congenital heart disease and treat them as you would treat any other patient. So that's easy. The problem comes when you get to our nightmare, which is the systemic right ventricle. So as I said, we don't have medications that have proven to improve survival in congenital heart disease, but we keep trying because we have to give something to these patients. So I made this table for a good chapter that I wrote last year. And this table summarizes all the randomized controlled trials that we have with guideline medical therapy in patients with systemic RV. I know when I go through the table because it's very busy and it's small on purpose, but there's only one trial that lasted for 8 years, that is a randomized controlled trial that they use valsartan and placebo. And it's the only trial that showed that the medical therapy reduces MACE, but doesn't reduce mortality. Every single study in that table was negative and didn't prove that medical therapy works in patients with systemic RV. More recently, that the group from the Brompton and the Georges Pompidou Hospital in France, they joined their population, and this is what I call a real-life study. They look at their population of almost 400 patients with systemic RV. More than 1/3 of them were patients with master ascending, and 1/3 was ccTGAs. The patients were quite good, quite asymptomatic. Only 8% was in class 3 or 4, and followed them for 7 years, and 40% of them were on medical therapy. With propensity score matching, they showed that neither ACE inhibitors or ARBs had any significant impact in reducing neither the heart failure incidence or the mortality in this population. So this is the evidence we have, and this has led to a significant division in the ACHD community between those that are believers that treatment doesn't work because the studies say that the treatment doesn't work, and those that believe that actually treatment might work or the studies might be a problem. Unfortunately, I'm on the second, so I'm gonna stop or go back to this table, and I'm gonna say, I'm gonna go in more detail through these studies because I think when you read literature, you have to read the literature critically and, you know, and get interpreted things properly. If you look at the studies, of course, we always complain congenital heart disease, we don't have enough patients. So look at the numbers. So if you do acquired heart disease, this is a joke, right? This is studies with the study with the biggest number of patients is 88. So that is nothing. But I don't want to go into the numbers because that's what we always complain about. If you look at the patients that we have treated in these studies, majority of them were okay. For patients in class 1, if you do treatment in patients with acquired heart disease in class 1, you actually might not achieve anything with that. So that's important. And most of these patients were okay because we need numbers and we just include everyone. But if you look at the ejection fraction, this is a systemic RV. Majority of these studies include patients with normal ejection fraction. So if we do a study with ACE inhibitors and normal ejection fraction in acquired heart disease, we had those studies, and all of them were negative. You don't have to give ACE inhibitors if your ejection fraction is not less than 40%. That's what the guidelines say. So have we selected the right patients? Questionable. If you look at the primary endpoints, I'm not going to go into detail, but majority of these studies look at change in right ventricular ejection fraction by MRI or change in right ventricular or systemic RV volumes with MRI. Try to do that at that endpoint in acquired heart disease. I'm sure that we would fail to show any change in the volumes in patients with acquired heart disease. But the last and the most important point, I think I showed you before at a study that showed that the physiology of ccTGAs and DTGA is completely different. So of course, we have to mix them because otherwise we don't have even numbers. But if you are treating two patients with two different physiologies, you cannot conclude that the medication doesn't work. So I think what the evidence tells us now is that we don't know if it works, but I don't think the evidence tells us that the medication doesn't work. I think we have to rethink in the ACHD community how we design the studies and how to look at different outcomes, but I don't think we have evidence to say that in systemic RV, medication doesn't work. And when you do this exercise of thinking of how I would design a new study, you have to take into consideration something that is obvious, that all of us know, that the right ventricle is different. I'm not going to embryology because that's for many years ago that we did this, but if you remember, the RV comes from a different heart field, it comes from the secondary heart field, which is not the most important thing here. The anatomy, I'm not going to go into detail. The RV is different, has only 2 layers than 1 layer, but what I think is extremely important, the mechanisms of adaptation to a pressure overload RV is completely different than a pressure overload LV, and doesn't matter whether the LV is in systemic position or the RV is in subpulmonary position. I'm not going to go into this busy slide into much detail, but I want to point out 3 or 4 points that makes the RV significantly different. So when you have a failing LV, what the LV does is to increase has the ability to increase the energy production in the RV, in the ventricle, to increase the contractility of the myocytes. You don't have that in a failing RV. So the RV has actually reduced the energy production when it has as a mechanism of adaptation for a pressure overload lesion. When you have a failing LV, you have a lot of antioxidants that are going to protect the LV or the myocytes from apoptosis, which is that doesn't happen in the failing RV, and the failing RV going to have a higher number of apoptosis, a higher risk of losing cells, and doesn't have the ability of producing new vessels to increase the perfusion of the ventricle, something that happened in the LV, and therefore you have a higher ischemia. So these are some examples how the RV works differently. But I think the one that is the most important, when I was a fellow, I was very obsessed with this already, and I just like heart failure by them. I think I spent probably 4 or 5 years looking for papers that say that if the receptors, if there's a problem with the receptor, if the AT2 receptors are the same in the RV or the LV, and actually I found it, and the receptors are the same. So you have exactly the same distribution of receptors in the surface of an RV that you have on a surface of an LV. The problem is the angiotensin signaling pathway is downregulated in a failing RV. And therefore, you might not know, but when you give ACE inhibitors to the patients, the body tries to inactivate them. And this metabolic inactivation is much higher in a failing RV than in a failing LV. And probably, and this is a hypothesis, we might need a higher dose of medications in order to block or to achieve the same outcome in these patients. So what I want to say with this is that, it's true that the studies have not proven that the medication work, but I don't think we have designed the proper studies. And I think in my personal experience, I've seen these medications work when you use it thinking with the physiology of the patient and the difference between the systemic LV or the systemic RV. So that's why there's something, a food for thought, mainly for the congenital community, that we have to probably do a better job than assuming that what we have already published just says that the medication doesn't work. Of course, that is systemic RV, which is easier than the other big problem that we have in heart failure and congenital heart disease, which is the Fontan circulation. So this is a diagram that depicts the biventricular circulation, which is, as you know, you have in a normal patient, you have 2 ventricles. So the LV pumps to the aorta, the blood comes back to the RV, to the RA, sorry, RV pumps to the PA, comes to the LA, and goes again to the systemic circulation. So if you have a normal heart, you have the ability to increase 5 times your cardiac output during the exercise. Your CVP is low. You have pulsatility, so something to the lungs, something pumps to the lungs, and your oxygen saturation is normal. That's what we are used to, right? If you have a Fontan, what we do is just they don't have pumping chamber under the ventricle. So they have a single ventricle that pumps to the body. The blood comes passively to the lungs, so comes to the Fontan circulation to the lungs, and they depend on the high venous pressure in order to be able to move the blood through the lung. So they need high venous pressure. The respiratory movements suck blood to the lungs and goes to the LV. So since the day that you complete the Fontan circulation, the cardiac output is reduced by up to 50%. But the average kid with a Fontan lives with a baseline 80% cardiac output. And when they exercise, at the beginning, when they are kids and when they are not failing, they might be able to increase the cardiac output up to 200%. But as they get older, their ability to increase cardiac output is significantly reduced. They live with a high CVP, which is going to have an impact in organ failure, like liver failure, and they don't have pulsatility. And when Francis Fontan did all his studies about, or his research about not having a right ventricle, he thought that was okay. And with time, we have learned that not having a pulsatility to the PA is a significant problem and increase your risk of developing high PVR. But also they live with low saturations. So some of them have up to 95%, the old Fontan have 98%, but over time they develop collaterals and they become cyanotic. And cyanosis is going to be another problem for heart failure. So what do we do with the Fontans? Well, we have no evidence whatsoever that guideline medical therapy works in Fontan circulation. But we are doctors, and you have a patient in front of you and is young, and you need to do something. And these these are 2 studies where 2 surveys, the left is in the US and the right is in Europe, where they look at, so they ask ACHD providers, what do you do with your Fontan circulation? From your Fontan patients, do you treat them? And you can see that many of the patients actually, we have no evidence, but they are in ACE inhibitors, not many on beta blockers, but actually many of them are on ACE inhibitors. And if you ask, why have you decided to give them ACE inhibitors? Most of them, they do it for ventricular dysfunction, as you can see here, on AV valve regurgitation. So I would like to make a pause here because this is one of my favorite concepts that I explain to the fellows all the time. I can see Jessica smiling already, but she has heard this a million times. So let's do an exercise. What happens in the body when you give a systemic vasodilator? So this is what happens in a biventricular circulation when you give a systemic vasodilator. If you try to reduce the afterload, your blood pressure is going to go down, and the only way for the patient to maintain cardiac output is increasing stroke volume. How we increase stroke volume in the circulation is what we do is to increase the end diastolic volume of the left ventricle. That's what happens automatically when you give a vasodilator to anybody. Well, the Fontan circulation has a problem, and they have a very limited ability to increase stroke volume. And whereas if you have a good Fontan at the beginning, they have that ability of increasing that stroke volume a little bit. As the Fontan fails and the patient becomes sicker, that ability goes away. So when you give an afterload reduction, actually, you might reduce the cardiac output. So it's the first medication that is stopped in the heart failure clinic as soon as a patient comes with Fontan and symptomatic, and even if they have a bad systemic ventricle, is the first medication to stop. I can tell you, you stop ACE inhibitors in a symptomatic Fontan, and within 2 weeks, they feel better. This is because of this physiology. I do not stop it in patients asymptomatic because it seems they have that ability and it's okay. But as soon as they become symptomatic, they need every single possibility of increasing cardiac output, and they notice the difference just stopping the medication. What I want to say with this is the physiology is very important, but there's another concept in Fontan that we forget. And to be honest, we forget the congenital heart disease provider. So for those that are not familiar with the Fontan circulation, so they have this, we bypass the circulation to the lungs. So we connect the IVC directly to the PA and the SVC directly to the PA. So in order to have maintain a big cardiac output, so the venous pressure is very high. Otherwise, they don't get very high. I thought in a good Fontan would be 12, 13, but we have Fontan with 15, 18, 20, and they don't walk around with a massive peripheral edema. Because if you have a normal patient with 20 of CVP, they would have a massive edema. How they do that is because the venous compliance of the Fontan circulation is significantly low in order to maintain cardiac output. That's how they do it. Well, if you give a medication that reduces venous compliance, I remind you that ACE inhibitors increase bradykinin, and bradykinin is the strongest venodilator of the body. So if you reduce the venous compliance, which is what we want to do in acquired heart failure, so you increase the venous compliance in a patient with Fontan circulation, so you made the venous more compliance. Actually, if you increase the venous compliance, you might reduce the cardiac output in this patient because they live with a very low venous compliance in order to have a good cardiac output. So again, physiology matters when you treat patients with congenital heart disease. I don't say that you cannot give ACE inhibitors in congenital heart disease patients with single ventricle. What I'm saying is you have to see who you have in front of you and at what stage of the Fontan circulation that patient is. But the sicker they get, which is when people start to treat them, actually, the less they tolerate this medication. Because many people are comfortable treating not treating the patient when they're okay, and we start to treat them when they become symptomatic. And that is the time that actually they have more side effects, and we can even cause harm treating this population. So recently, every time that we have a new medication, a new kid in the block in acquired heart disease, we try to do the same in congenital heart disease. So this is, I don't want to go through the paradigm trial, no, but Entresto came to the world in 2014, and since then we have tried to give Entresto to our population. So these are the 4 studies published until 2021. I think the 3 studies in that table are pretty useless because, as I said, if we have population that have different physiology. I think having studies that you publish your experience in systemic left ventricle, well, I know that systemic left ventricle doesn't matter whether you have congenital heart disease or not, it's going to work. So mixing populations, I don't think is really helpful. So the first 3 studies show nothing, but I think it's not very helpful because of the mix of the population. The 4th study, the bottom study, I think is very interesting because actually it's the group from Leuven, and they did a very good study. So they only chose patients with DTGA, so homogeneous population. They only chose patients that actually have proper RV dysfunction, systemic RV dysfunction, 35%. And they chose patients that were truly symptomatic. So class 2 or 3, most of the patients. They gave them Entresto, they go to maximum dose. They follow them for 6 months, and they showed an improvement in NT-proBNP after 6 months of therapy, improvement in systemic RV function, but using global longitudinal strain, which is probably a much better way of looking at RV function that's MRI by volumes, changing in volumes in MRI. They didn't show any difference in functional class or any improvement in quality of life of these patients. But more recently, this study just is off the press. The group from Naples, they published at their experience with Entresto, so 51 patients. Again, majority of the patients symptomatic. They mixed the population. So that's one criticism to this study is the mix of the population. But they use patients with significantly reduced ejection fraction. After a year of therapy, they showed improvement in RV function, again, measured by fractional area change and GLS. So I think that both studies use the same way of measuring systemic RV function, and probably that's the way to go. And they went 1 point beyond, and they use RV 3D. They measure the ejection fraction with 3D, and they also show an increase in ejection fraction with 3D. Interestingly, they show a reduction in BNP for the first 6 months, the NT-proBNP, but after a year, the NT-proBNP went back to the baseline. If you look at the functional class of the patient improved significantly and kept improving after 6 months on therapy. I think this study show one concept that I also share is that if you want to see improvement in congenital heart disease with medical therapy, you have to wait. So it takes longer than acquired heart disease for them to notice the difference with medication. So I think these 2 studies are quite encouraging that Entresto might be the way to go for systemic RV. Of course, now we have a new kid on the block, which is SGLT2. Of course, we want to do that, to use that in congenital heart disease. I think SGLT2, I call it the aspirin of the 21st century, because I think all of us are going to end up taking SGLT2 because it's good for your heart, it's good for your brain, it's good for your kidneys, for your gut, good for everything. So, you know, probably the last thing that is good is for diabetes. That's what we're developed for, but it's good for everything else. So I'm not going to go into detail or explain to a group of cardiologists what SGLT2 do, because, you know, all of us know what the SGLT2 medications they do, but I want to focus on what the cardiovascular features of the SGLT2 might make them a very appealing drug for congenital heart disease. As you know, they have the ability to decrease the activation of the RAAS of the angiotensin pathway, but they have the ability to decrease activation of the sympathetic nervous system. So if you have a patient that, like the TGAs with master, that they depend on heart rate to have cardiac output, and you don't want to give beta blockers because we know that, you know, that would be a reduction of sympathetic nervous system, you might have a drug that actually might do that job. Not as good, but, you know, might have something to explore in this patient. They have the ability to hold the pressure overload induced myocardial fibrosis, one of the main problems we have in systemic RVs. The reverse cardiac remodeling. They improve myocardial energetics. If you remember from that BC slide with on systemic RV, the patients with systemic RV that fail, they don't have the ability to increase energy in the myocytes. And actually, SGLT2, that is very well proven in acquired heart disease. They have the ability to increase basically increase the calcium in the sarcomere, and that leads to increasing in contractility, and increased energetics leads to increasing in contractility. But I think the most appealing part of these drugs for us is the glucose that they produce. As you know, they increase the diuresis. They do it, they reduce interstitial fluid rather than intravascular fluid. That's a very interesting concept when you deal with preload dependent circulation patients, that like the Fontans, that they depend on preload to have cardiac output. So if you can take water away from the interstitial and not taking it from the intravascular fluid, is actually more beneficial for these patients. So theoretically, these drugs might be a solution for some of the heart failure in congenital heart disease. As I said, every time that there's a new kid in the block, we're going to do it. So this is the first case report published in last year in the ESC Heart Failure Journal. That is, I know the first author, and what they did, they had a patient with a ccTGA, what was a nightmare. I'm not going to go into detail of the nightmare, but million operations, TBR included, severe heart failure. With all of these were admissions for heart failure. Patient maximized in treatment. The patient was in on Entresto. They had a CRT included. The patient kept having admissions, and they just were desperate, and they chose. And they just decided to give the patient SGLT2. Well, the SGLT2, as you can see, reduced improved the patient's functional class, reduced significantly the heart failure hospitalizations of the patient, improved the RV function, again measured by GLS, by strain rate and global strain, and improve the exercise capacity of the patient. So this is a case report, and we cannot make conclusions with case reports. But now everyone is start to publish their experience. So this is just off the press. This paper was published 2 weeks ago. This is the group from Penn Medicine that they just published their experience in SGLT2. And again, I think we are making the same mistake again. We are publishing everything. So every single patient with congenital heart disease. So there's only 8 patients with ccTGA. So there were patients with biventricular circulation, but again, patients with good ejection fraction, they use every single SGLT2. But the interesting part, they show a reduction in BNP. They show a significant weight loss and no significant complications. So I think the paper can say that the medication is safe. I don't think we can say much more, but I think the mechanism of action of the SGLT2 make them a very appealing drugs for congenital heart disease patients. Of course, doing heart failure and transplant, I cannot finish a talk in heart failure without talking about assist device and transplant. So this is a shocking slide that I always bring to the heart failure talks that say that in black you have the patients with ACHD and you have in gray the non-ACHD patients. And if you look who gets a BAT, yes, I don't think I have to explain that graph. So basically, we don't do BATs in congenital heart disease. But even if you look at what happened with the transplant in the last 10 years, which this is a 10 years period, they look at the transplants and BATs in the heart failure patients, actually the congenital heart disease patients transplant is going down. So we have a population that is growing, is bigger, but they are in significant disadvantage for a million reasons that we can discuss in when talk about in the discussion. But I want to bring to people's attention that these are data from the Intermax registry of outcomes in BATs in congenital heart disease, and there's only 300 patients compared to the thousands of patients with acquired heart disease. But I want just to draw your attention to this graph here, and this graph here shows that the survival of patients with congenital heart disease, with any kind of congenital heart disease, but single ventricle. So we are not talking about Fontan patients. That if you put a BAT in a patient with a congenital heart disease, including systemic right ventricles, this is true. The mortality at the beginning is higher, but after a year, the survival is exactly the same than acquired heart disease patients. So we can't take these patients away from the opportunity of having a technology that we are using significantly more in acquired heart disease, because actually, than in centers with high volume and experience, the survival is the same. And when we look at transplant, things are actually even better, because these are data from the SGLT registry from last year, and they published the data 5 years before. But these are data on the website, taken from the website from the last year report. And if you look at the survival per diagnosis, patients with congenital heart disease have a higher mortality in the first year. That's true. That's perioperative related. But if you survive a year with a heart transplant and you have congenital heart disease, actually you live longer. So, you know, we don't give organs to these patients, and you live longer no matter what is your congenital heart disease, whether you have a Fontan or whether you have a systemic RV or you have a systemic left ventricle. So we don't give them the same opportunity, but actually probably they would make much more of the organs than a patient with acquired heart disease. And this is how I see congenital heart. When this paper was published in 2016, actually was reading my brain how I see congenital heart disease heart failure. So you see that, you know, you have a patient with acquired heart disease, you might have an event of heart failure, you stabilize, you might have another one, but these patients, they live with congenital heart failure, with the risk of developing heart failure. They are born with a structural heart disease. Guidelines, if you go to the guidelines, the risk of having heart failure is having a structural heart disease. So you have congenital heart disease, you are already at risk of having heart failure. And they go through nightmares in their lives. They have heart failure admission, they have an operation, they have another surgery, they have an ablation. And after, when they get to the listing for transplant, they are too sick already. And after, it's very normal that these patients lose the ability to have a transplant or die on the waiting list. So what we did in Toronto, and sorry for the slides that's changed from the Mac to PC, but what we did in Toronto, so this was the model that we have from heart failure and congenital heart disease, and this was previous my time, that you know, if you had a patient with congenital heart disease would come to the congenital heart disease group. If the patient had heart failure or needed a transplant, we would refer the patient to the transplant group. They would also have patients that would be referred to the transplant program for them to assess for transplant, and we would not be involved in that. And I've been in Toronto 7 or 8 years ago, the model changed, and we have now an advanced heart failure clinic. So we have a clinic that is run by Lucy Rhodes and myself. So I actually joined the group in Toronto as part of the heart failure group. That's why I moved from London to Toronto. And every single patient with heart failure in the unit come to us. So our colleagues just refer majority of the referrals are from actually in-house. But every single patient that is referred to the program for transplant assessment and gets to the transplant program, because many people are still referring to the transplant program, the patient come to us, the transplant program don't see the patient. We see the patient, we see if there's any structural thing we might have to do on the patient before considering transplant. If we consider transplant, we are the ones doing all the assessment. We are the ones that coordinate the care with the heart transplant team, with the cardiac surgeons, with the cardiac anesthetist, with the lung transplant team for the heart transplant. And the key point of this group is that our transplant is done by congenital heart disease surgeons since this model started. And you know, we are now looking at the outcomes of the population, and the survival in the program changed significantly since this model wasn't started. But the most important thing is that you have the patient with heart failure in your clinic, and you are able to decide earlier if the patient is a transplant, or just monitor the patient much closer that if the patient is not in a heart failure clinic. So just to finalize, so heart failure is, I hope that I convince you that it's very common in congenital heart disease, and is the leading cause of death after 40 years old, so as young as 40 years. But the different anatomy and different physiology makes significantly challenging to treat these patients. And both anatomy and physiology need to be considered when you give medications to these patients. I haven't said today, do not give medication. Haven't said give medication. I said, look at the patient you have in front of you, both anatomically and physiologically. Don't dismiss these patients for assist devices because, you just need to get the expertise, but if you have the expertise, they do well with assist devices. If you transplant them, they live longer. So they should not be undermined or dismissed from the transplant list because they have congenital heart disease and it's very complex to transplant them because it is complex, but can be done and can be done safely. And early referral, I'm of course, this is what I do, but I am a massive defendant of ACHD heart failure clinics. I think that the ACHD community has to either join with the heart failure community or get people like I'm trained in both fields, so it's easier probably for me to do heart failure and congenital heart disease, but either train the congenital heart disease providers in heart failure or work very close with heart failure providers. Both models are in the US, and have a clinic that is specifically for these patients to have a long-term follow-up, and that change significantly their outcome. And with that, just thank you very much. I'm happy to take any questions.
Thank you so much for that wonderful talk. That was great. Want to put it into the chat? That would be great.
It's Kristen Lyons. I'm here virtually. I'm one of the heart failure cardiologists here, and we do see our congenital patients when they're referred to us when the congenital team here is thinking they may need a transplant either in the near or maybe they're slightly farther off future. And one of the things we do to follow these patients is serial CPETs, which, as you've already alluded to, especially with the baseline value, their values are always lower than what we say the normal age predicted. When you do serial CPETs, what is your percent, say, reduction or reduction in VO2 that would be a significant decrease in, say, a Fontan patient when you're following it serially to help decide whether or not to pull the trigger on moving forward with advanced therapies?
So that's a great question. So I don't need to repeat the question from online. No. So yes, so it's a great question. So if it's not a Fontan patient, it's difficult because we don't know. You have to just make sure that there is nothing else that is preventing the patients for having a bad day, a bad CPET. But in Fontans, we have that data. So the group from Leuven look at their population, and they came up with the 15% is your cutoff. If you have a 15% reduction in the peak VO2 in a Fontan patient, that is a marker that things go in the wrong direction. Having said that, I never do trigger the button with a single CPET. I always try to have 2 serial CPETs. So if I'm consent, I will repeat the CPET in 6 months. And we have just, I think almost about a year ago now, we started in Toronto what we call the Life Medicine Style Program, which is an exercise program for Fontan patients. And you will be surprised that you get the patients that have a low CPET. We send them to the program. After 3 months of training, many of them actually increase their PVO2. So if it's only the CPET what is changing, I try to make sure that it's not just a physical deconditioning or something else that actually might be modifiable. But if not, 15% is that cutoff that we use for considering that things are going the wrong direction.
Great, thank you very much.
No, well, no, yes. So, I mean, RV failure is my other obsession. The fellows know that is my other field of obsession. I mean, we know that ACE inhibitors do not work in RV failure, and RV failure will be another hour talk. But just as a principle for RV failure, what is true in RV failure is a preload dependent failure. That's completely true. A patient with a failing RV in subpulmonary position, that's good. let's do an example. I don't know, but patient with APE, for example. It's a preload dependent circulation. So you have to be careful with how you reduce with your diuretics, how much volume you reduce. These inhibitors do not work. Actually, try and make it worse because you venodilate them and you reduce the preload. But the principles are different. The RV failure is altogether a completely different game that we don't know. None of these medication work. The ACE inhibitors don't work, beta blockers don't work. But the management of acute RV failure is itself a single topic. So Steve Rayner is asking that how we structure our program in Toronto in the heart failure clinic with if we have nurses or we ask physicians. So I wish I could have nurses. That's my wishful thinking, but no, the truth is we don't. It's a completely physician-led. So it's Lucy and myself, and it's all of us. So we don't have. I would like to have nurses. We have support, so we have the possibility to use what Medley, which is the remote monitoring of patients with heart failure. That is a program developed by the heart failure program in Toronto. And if we need to monitor patients that live remotely, we use Medley, and Medley has 4 nurses looking after the program. So you just give them the instructions. So these are the parameters I need. If this happened, this triggers, and the patient might need an extra dose of metolazole or whatever. You have that possibility, but 95% of the population is managed just by physician-directed management. Thank you very much. Thank you. I follow Steve. That whatever Steve does, I just do it.